Hello everyone, I'm Dr. Ali Bozorgi, cardiac electrophysiologist, and very welcome back to ECG Refresher Part 14. Today, I'll be sharing an interesting case of a 33 years old man presented to the emergency room complaining of dyspnea. You can see 12-lead ECG. I suggest you pause the video and have a look at the ECG. After a moment, I'll provide you with an in-depth breakdown of what we are seeing. As we review the ECG, focus on QRS complex. Observe the reduced voltage, suggestive of low voltage ECG. Although it may not fully meet the exact criteria for low voltage ECG, it's obviously low voltage than usual. Let's quickly explore the definition and causes of low voltage ECG. Definition: a QRS amplitude of equal 5 or less than 5 mm in all limb leads, or equals or less than 10 mm in all chest leads. Potential causes to consider is large pericardial effusion, large pleural effusion, large body habitus, emphysema, large pneumothorax, subcutaneous emphysema, infiltrative cardiomyopathy, such as sarcoidosis, amyloidosis, or hemochromatosis, hypothyroidism, cardiomyopathy, dilated cardiomyopathy, myocarditis, and large myocardial infarction. Back to ECG. The second most prominent finding in this ECG is electrical alternance. You can see, for example, in V2, consecutive normally conducted QRSs that alternates in height. A typical cause of electrical alternance is pericardial effusion and is due to periodic wobbling of the heart in the pericardium. In cases of severe pericardial effusion, the heart in certain bits is near the chest, and in others it is more distant, causing electrical alternance. However, alternating axis shift may be due not to mechanical shifting of the heart, but to the alternating conduction abnormalities, such as intermittent fascicular or bundle branch block. In 1978, Klein coined the term pseudo-electrical alternance in a case report of intermittent left anterior hemiblock in which the axis shifted every other bit due to development of alternating normal and then leftward axis shift. So, beware of pseudo-alternance. Back to our ECG. We had a relatively low voltage QRS complexes with obvious electrical alternance, strongly suggesting a diagnosis of severe pericardial effusion. Our patient had a previous medical history of thymic lymphoma and, having undergone chemotherapy 2 years ago, showed no detectable malignancy in PET scan 1 year ago. The patient underwent pericardiocentesis. The fluid was turbid, white, milky in appearance, with a triglyceride level of more than 1000 mg per deciliter. The mechanism by which chyle accumulates within the pericardium is believed to be secondary to abnormal or damaged lymphatics, or due to elevated pressure within the thoracic duct that results in chyle reflux into the pericardium. For more details on this case, please visit cardiocase.com and read case 705, elaborated upon by Dr. Houshang Bavandpour. Stay tuned for our next videos where we'll discuss more ECG insight. Thank you for joining us, and until next time.